Now, jaundice. Over 50% of all newborn infants become visibly jaundiced. This is because there is marked physiological release of hemoglobin from the breakdown of red cells because of the high hemoglobin concentration at birth. The red cell lifespan of newborn infants 70 days is markedly shorter than that of adults 120 days. Hepatic bilirubin metabolism is less efficient the first few days of life. Neonatal jaundice is important as it may be a sign of another disorder, for example, hemolytic anemia, infection, inborn error of metabolism, liver disease. Unconjugated bilirubin can be deposited in the brain, particularly in the basal ganglia, causing kernicterus. Kernicterus is the encephalopathy resulting from the deposition of unconjugated bilirubin in the basal ganglia and brainstem nuclei. It may occur when the level of unconjugated bilirubin exceeds the albumin binding capacity of bilirubin of the blood. As this free bilirubin is fat soluble, it can cross the blood-brain barrier. The neurotoxic effect vary in severity from transient disturbance to severe damage and death. Acute manifestations are lethargy and pure feeding. In severe cases, there is irritability, increased muscle tone, causing the baby to lie with an arched back, opisthotonus, seizures and coma. Infant who survive may develop choriothedoid cerebral palsy due to damage to the basal ganglia. Learning difficulties and sensory neural deafness. Kernicterus used to be an important cause of brain damage in infants with severe rhesus hemolytic disease, but has become rare since the introduction of prophylactic anti-D immunoglobulin for rhesus-negative mothers. However, a few cases of kernicterus continue to occur, especially in slightly preterm infants, 35 to 37 weeks, and dark skin toned infants in whom jaundice is more difficult to detect. This has led NICE to issue guidelines on management of neonatal jaundice. Clinical evaluation. Babies become clinical jaundice when the bilirubin level reaches about 80 micromole per liter. Management varies according to the infant's gestation age, age and onset, bilirubin level, and rate of rise, and the overall clinical condition. Age at onset. Age of onset is a useful guide to the likely cause of the jaundice. Jaundice less than 24 hours of age. Jaundice starting within 24 hours of birth usually results from hemolysis. This is particularly important to identify as the bilirubin is unconjugated and can rise very rapidly and reach extremely high levels. Hemolytic disorder. Rhesus hemolytic disease. Affected infants are usually identified antenatally and monitored and treated if necessary. The birth of a severely affected infant with anemia, hydrops, and hepatosplenic mechanism rapidly developing severe jaundice has become rare. Antibodies may develop to rhesus antigen other than D and to the Kell and Duffy blood groups, but hemolysis is usually less severe. ABO incompatibility is now more common than rhesus hemolytic disease. Most ABO antibodies are IgM and do not cross the placenta, but some O group O women have an IgG anti-A hemolysin in their blood, which can cross the placenta and hemolyze the red cells of a group A infant. Occasionally, group B infants are affected by anti-B hemolysins. Hemolysis can cause severe jaundice, but is usually less severe than in rhesus disease. Infant's hemoglobin level is usually normal or only slightly reduced, and in contrast to rhesus disease, hepatosplenomegaly is absent. The direct antibody test, Coombs test, which demonstrates antibody on the surface of red cells, is positive. The jaundice usually peaks in the first 12 hours to 72 hours. This is the breakdown product of hemoglobin is unconjugated bilirubin, indirect bilirubin, which is insoluble in water but soluble in lipids. It is carried in the blood bound to albumin. When the albumin binding is saturated, free and unconjugated bilirubin can cross the blood-brain barrier as it is lipid soluble. Unconjugated bilirubin bound to albumin is taken up to the liver and conjugated by glucuronyl transferred to conjugated bilirubin, which is water soluble, and excreted in bile into the gut, and then as stercobilinogen and urobilinogen. Some bilirubin in the gut is converted to unconjugated bilirubin, reabsorbed via the enterohepatic circulation and metabolized in the liver. This is the whole conjugation and breakdown. Now, the causes of neonatal jaundice: jaundice starting at less than 24 hours, jaundice at 24 hours to 2 weeks of age, and jaundice at more than 2 weeks of age. Jaundice starting at less than 24 hours of a hemolytic disorder, rhesus, ABO, G6PD, spherocytosis, pyruvate kinase deficiency, and congenital infection. Jaundice at 24 hours to 6 weeks, physiological jaundice, breast milk jaundice, infection, UTI, and hemolysis, G6PD deficiency, ABO incompatibility, bruising, polycythemia, and Crigler-Najjar syndrome. Jaundice at more than 2 weeks of age, unconjugated, physiological breast milk jaundice, infection, particularly urinary tract, hypothyroidism, hemolytic anemia, G6PD, high GIT, obstruction. For example, pyloric stenosis, conjugated, more than 25 micromole, bile obstruction, and neonatal hepatitis. G6PD deficiency mainly in people originating in the Mediterranean, Middle East, and Far East, or in Africa, mainly affects male infants, but some female develop significant jaundice. Parents of effective infants should be given a list of drugs to be avoided, as they might participate hemolysis, spherocytosis. This is considerably less common than G6PD. There is often, but not always, family history. The disorder can be identified by recognizing spherocytes on the blood film. Congenital infection, jaundice at birth, can also be from congenital infection. In this case, the bilirubin is conjugated, and infants have other abnormal clinical signs such as growth restriction, hepatosplenomegaly, and thrombocytopenic purpura. Jaundice at 2 days to 2 weeks of age, physiological jaundice. Most babies who become mildly or moderately jaundiced during this period have no underlying cause, and the bilirubin has risen. As infants is adapting to transition from fetal life, the term physiological jaundice can only be used after other causes have been considered. Breast milk jaundice. Jaundice is more common and more prolonged breastfeed. Infants' hyperbilirubinemia is unconjugated. The cause is multifactorial but may involve increased enterohepatic circulation of bilirubin, dehydration. In some infants, jaundice is exacerbated. Milk intake is poor from a delay in establishing breastfeeding. An infant becomes dehydrated, more than 10% weight loss from birth weight. Breastfeeding should be continued, although supplemental feeding is sometimes needed to reverse the dehydration. In some infants, IV fluids are needed to correct dehydration. Infection: an infected baby may develop unconjugated hyperbilirubinemia from poor fluid intake, hemolysis, reduced hepatic function, and an increase in the enterohepatic circulation. If infection is suspected, appropriate investigation treatment should be instigated. In particular, urinary tract infection may present in this with other causes. Although jaundice from hemolysis usually presents the first day of life, it may occur during the first week. Bruising and polycythemia, venous hematocrit more than 0.65 will exacerbate the infant jaundice. The very rare Crigler-Najjar syndrome, in which glucuronide transferase is deficient or absent, may result in extremely high levels of unconjugated bilirubin. The causes and management of jaundice at over 2 weeks or over 3 weeks. Preterm infants of age, persistent and prolonged neonatal jaundice are different and discussed separately below. Severity of jaundice. Jaundice can be observed more easily by blanching the skin with one's finger. Jaundice tends to start on the head and face and then spread down the trunk and limbs. If the baby is clinically jaundiced, the bilirubin should be checked with a transcutaneous bilirubin meter or blood sample. It is easy to underestimate in dark skin tone and preterm babies. Low threshold should be adopted for measuring the bilirubin of these infants. A high transcutaneous bilirubin level must be checked with the blood lab measurement. It is now recommended in the UK that all babies should be checked clinically for jaundice in the first 72 hours of life. Whether hospital, home, or if clinically jaundice, a transcutaneous measurement should be obtained. Rate of change: the rate of rise tends to be linear until a plateau is reached. So serial measurements can be plotted on a chart and used to anticipate the need for treatment before it rises to a dangerous level. Gestation preterm infants are more susceptible to damage from raised bilirubin, so the intervention threshold is lower. Clinical condition: infants who experience severe hypoxia, hypothermia, any serious illness may be more susceptible to damage from severe jaundice. Drugs that may displace bilirubin from albumin, for example, sulfonamides and diazepam, are avoided in newborn infants. Management: poor milk intake dehydration will exacerbate jaundice and should be corrected, but studies have failed to show that routinely supplementing breastfed infants with water dextrose solution reduces jaundice. Phototherapy is the most widely used therapy with exchange transfusion for severe cases. Now, the case history: jaundice needing phototherapy. A term: if male infant was noted to be markedly jaundiced at 10 years of age, his bilirubin 170 direct antibody test positive, maternal blood group O rhesus, and his blood group was A rhesus. A diagnosis of AB incompatibility of male. He was started on intensive phototherapy, and his bilirubin closely monitored and plotted on the bilirubin chart for term infants. His bilirubin resolved phototherapy, so immunoglobulin therapy and exchange transfusion were not required. The bilirubin chart of bilirubin and time from birth. Now, the phototherapy: light wavelength 450 nanometer from the blue-green band of the visible spectrum converts unconjugated bilirubin into harmless water-soluble pigment excreted predominantly in the urine. It is delivered with an overhead light source placed at an optimal distance above the infant to achieve high irradiance. Although no long-term sequelae of phototherapy from overhead light has been reported, it is disruptive to normal care of the infant and should not be used indiscriminately. The infant's eyes are covered as bright light is uncomfortable. Phototherapy can result in temperature instability as the infant is undressed, macular rash, and bronze discoloration of skin if the jaundice is conjugated. Continuous multiple intensive phototherapy is given if the bilirubin is rising rapidly or has reached a high level. Exchange transfusion is required if the bilirubin rises to levels that are considered potentially dangerous. Blood is removed from the baby in small aliquots, usually from anterior line or the umbilical vein, and replaced with donor blood via peripheral or umbilical vein. Usually twice the infant's blood volume, 2 into 90 ml per kg, is exchanged. Donor blood should be as fresh as possible, screened to exclude cytomegalovirus, Hep B, C, and HIV infections. The procedure does carry some risk of morbidity and mortality. Phototherapy has been very successful in reducing the need for exchange transfusion in infants with rhesus, hemolytic disease, or ABO incompatibility unresponsive to intensive therapy. IV immunoglobulin reduces the need for exchange transfusion. There is no bilirubin level known to be safe or which will definitely cause kernicterus. In rhesus hemolytic disease, it was found the kernicterus could be prevented if the bilirubin was kept below 340 micromole per liter, that is 20 milligram per deciliter. Now, the summary assessment of neonatal jaundice: severity, clinical assessment: breast skin to assess jaundice, which progresses from head to limbs, may underestimate if dark skin preterm. If clinically jaundice, check bilirubin with transcutaneous meter or blood sample. Gestation: lower treatment threshold if preterm. Age: if less than 24 hours, likely to be hemolysis and potentially serious. If more than 2 weeks, 3 weeks if preterm. Persistent neonatal jaundice, need to check if unconjugated or conjugated. Well or unwell, check for clinical evidence of sepsis and if dehydrated. Risk factors: hemolysis, check for antenatal antibodies if mother is blood group O, ABO incompatibility if Mediterranean, Far Eastern, and African origin, G6PD deficiency, sepsis, unwell acidosis, low serum albumin if mired, needing treatment. Plot bilirubin of gestation specific chart according to age since birth. Plot rate of change bilirubin to identify potentially high levels. As there is a consensus among pediatricians on the bilirubin level for phototherapy and exchange transfusion, guidelines have been established by NICE to ensure uniform practice in the UK. Jaundice at more than 2 weeks, jaundice in babies more than 2 weeks old, 3 weeks if preterm, is called persistent prolonged neonatal jaundice. The key feature is that it may be caused by biliary atresia, and it is important to diagnose biliary atresia promptly, as delaying surgical treatments adversely affects outcome. However, in most infants with persistent neonatal jaundice, hyperbilirubinemia is unconjugated, and this needs to be confirmed on laboratory testing. In prolonged unconjugated hyperbilirubinemia, breast milk jaundice is the most common cause, affecting up to 15% of healthy breastfed infants. The jaundice rarely fades and disappears by 4 to 5 weeks of age. Infection, particularly of the urinary tract, need to be considered. Congenital hypothyroidism may cause prolonged jaundice before the clinical features of coarse facies, dry skin, hypertonia, and constipation become evident. Affected infants should be identified on routine neonatal biochemical screening, Guthrie test. Conjugated hyperbilirubinemia more than 25 micromole per liter is suggested by the baby passing dark urine and pigmented pale stools, hematomegaly, and poor weight gain are other clinical signs that may be present. It causes include neonatal hepatitis syndrome and biliary atresia with improved prognosis of biliary atresia with early diagnosis. Respiratory distress in term infants, newborn infants with respiratory problems develop the following signs of respiratory distress: tachypnea, more than 60 breaths per minute, labored breathing with chest wall recessions, particularly sternal subcostal drawing and nasal flaring, respiratory grunting, cyanosis is severe. The cause in term infants are listed. Affected infants should be admitted to the neonatal unit for monitoring of heart, respiratory rates, oxygenation, circulation. A chest X-ray will be required to help identify the cause, especially those causes that may need immediate treatment, for example, pneumothorax or diaphragmatic hernia. Additional ambient oxygen, respiratory support that may be non-invasive, for example, CPAP, high-flow nasal cannula therapy, or else mechanical ventilation and circulatory support are given as required. Transient tachypnea of the newborn. This is by far the most common cause of respiratory distress in term infant. It is caused by delay in the resorption of liquid. Lung liquid is more common after birth by C-section. Chest X-ray may show fluid in the horizontal fissure. Additional ambient oxygen may be required. The condition usually settles within the first day of life, but can take several days to resolve completely. This is diagnosis made after consideration and exclusion of other causes such as infection. Meconium aspiration. Now the table showing the causes of respiratory distress in term infants. Pulmonary common are transient tachypnea of the newborn. Less common is meconium aspiration, pneumonia, respiratory distress, pneumothorax, persistent pulmonary hypertension newborn, milk aspiration rare, diaphragmatic hernia, tracheoesophageal fistula, pulmonary hypertonia, hypoplasia, area obstruction, for example, choanal atresia, pulmonary hemorrhage, non-pulmonary congenital heart disease, hypoxic ischemia, neonatal encephalopathy, severe anemia, and metabolic acidosis. Now, meconium aspiration, meconium is passed before birth by 8 to 20% of babies. It is really passed by preterm infants and occurs increasingly. The greater the gestational age, effective 20-25% deliveries by 42 weeks, it may be passed in response to fetal hypoxia. Asphyxiated infants may start gasping, aspirate meconium before or at delivery. Meconium is a lung irritant and results in both mechanical obstruction and a chemical pneumonitis, as well as predisposing to infection. In meconium aspiration, lungs are overinflated, accompanied by patches of collapse and consolidation. There is a high incidence of air leak leading to pneumothorax and mediastinal. Mechanical ventilation is often required. Infants with meconium aspiration may develop persistent pulmonary hypertension newborn, which may make it difficult to achieve adequate oxygenation despite high pressure ventilation. Severe meconium aspiration is associated with significant morbidity and mortality. There is no evidence that aspiration of meconium from an infant oropharynx immediately after delivery of the head or removal of meconium by intubation and tracheal suctioning after birth reduces incidence severity of meconium aspiration. Pneumonia, prolonged rupture of the membranes, chorioamnionitis in low birth weight, predisposed to pneumonia, infants with respiratory distress usually require investigation to identify any infection. Broad-spectrum antibiotics are started early until the reaction results of the infection strains are available. Pneumothorax may occur spontaneously in up to 2% of deliveries. It is usually asymptomatic but may cause respiratory distress. Pneumothoraces also occurs secondary to meconium aspiration, respiratory distress syndrome, or as a complication of mechanical ventilation. Milk aspiration, this occurs more frequently in preterm infants and those with respiratory distress or neurological damage. Babies with bronchopulmonary dysplasia often have gastroesophageal reflux, which predisposes to aspiration. Infants with a cleft palate are prone to aspirate respiratory secretions or milk. Persistent pulmonary hypertension, newborn life-threatening condition is usually associated with birth asphyxia, meconium aspiration, septicemia, or RES. It sometimes occurs as a primary disorder. As a result of high pulmonary vascular resistance, there is right to left shunting within the lungs and at atrial and ductal level. Cyanosis occurs soon after birth. Heart murmurs and signs of heart failure often absent. A chest X-ray shows the heart is of normal size and there may be pulmonary oligemia. An urgent echocardiogram is required to exclude congenital heart disease and identify the signs of pulmonary hypertension, such as raised pulmonary pressures and tricuspid regurgitation. Most infants require mechanical ventilation, security support in order to achieve adequate oxygenation. Inhaled nitric oxide, a potent vasodilator, is often beneficial. Another vasodilator, sildenafil, is also a treatment option for some babies. High frequency oscillatory ventilation is sometimes helpful. ECMO, extracorporeal membrane oxygenation, where the infant is placed on heart and lung bypass for several days, is indicated for severe but reversible cases, but is only performed in a few specialist centers. Diaphragmatic hernia, this occurs is in about 1 in 4,000 births. Many are now diagnosed with antenatal ultrasound screening in the newborn period. It usually presents with failure to respond to resuscitation or as respiratory distress. In most cases, there is left-sided herniation of abdominal contents through the posterior foramen of the diaphragm. Apex beat heart sound will then be displaced to right side of chest with poor rate entry to left chest. Vigorous resuscitation may cause a pneumothorax in normal lung, thereby aggravating the situation. The diagnosis is confirmed by X-ray of the chest and abdomen. Once the diagnosis is suspected, a large nasogastric tube is poised and suction is applied to prevent distension of the intrathoracic bowel. After stabilization, the diaphragmatic hernia is repaired surgically, but is more in infants. Hernia is repaired in most infants with this condition. The main problem is pulmonary hypoplasia, where compression by the herniated viscera throughout pregnancy has prevented development of lungs in fetus. If the lungs are hypoplastic, mortality is high. Other causes of respiratory distress are listed in table. When, due to heart failure, abnormal heart sounds and heart murmurs may be present, auscultation and large liver from venous congestion is a helpful sign. The femoral arteries may be palpated in all infants with respiratory distress, as coarctation of aorta, interrupted aortic arch are important causes of heart failure in newborn infants. Now, infection, the time of highest risk in childhood for acquiring a serious invasive bacterial infection in neonatal period. Infections fall into two broad categories: early onset and late onset sepsis. Early onset sepsis less than 48 hours after birth. Bacteria has ascended from the birth canal and invaded the amniotic fluid. The fetus is secondarily infected because the fetal lungs are in direct contact with infected amniotic fluid. These infants have pneumonia and secondary bacteremia, septicemia. By contrast, in congenital viral infection, early onset infection with Listeria monocytogenes, fetal infection is required via the placenta following maternal infection. The risk of early onset infection is increased if there has been prolonged or premature rupture of amniotic membranes and when chorioamnionitis is clinically evident, such as when the mother has fever during labor. Presentation is with respiratory distress, temperature instability, and the other clinical features which may be present, which are listed in box. The box which shows clinical features of neonatal sepsis, fever or temperature instability or hypothermia, poor feeding, vomiting, apnea and bradycardia, respiratory distress, abdominal distension, jaundice, neutropenia, hypoglycemia, shock, irritability, seizures, lethargy and drowsiness, in meningitis, tense or bulging fontanelle, head retraction, that is opisthotonus. A chest X-ray is performed together with a septic screen. A full blood count analysis is performed to detect neutropenia as well as blood cultures. An acute phase reactant C-reactive proteins helpable takes 12 to 24 hours to rise. So one normal result does not include infection, but two consecutive normal values are strong evidence against infection. Antibiotics are started immediately without waiting for culture results. Intravenous antibiotics are given to cover group B streptococci, L monocytogenes, and other gram-positive organisms, usually benzyme penicillin or amoxicillin, combined with cover for gram-negative organisms, usually an aminoglycoside such as gentamicin. If cultures and C-reactive proteins are negative and the infant has no clinical indicators of infection, antibiotic can be stopped after 36 to 48 hours. If the blood culture is positive or if there are neurological or generalized signs, CSF must be examined and cultured. Late onset infection more than 48 hours after birth. Source of infection is often the infant's environment. Presentation is usually non-specific. Nosocomially, acquired infections are an inherent risk in a neonatal unit, and all staff must adhere strictly to effective hand hygiene measures to prevent cross-infection. Neonatal intensive care, the main source of infection are indwelling central venous catheters from parenteral nutrition. Invasive procedures that break the protective barrier of the skin and tracheal tubes. Coagulase negative Staph epidermidis is the most common pathogen, but the range of organisms is broad, include gram-positive bacteria, Staph aureus and Enterococci, Faecalis, and gram-negative bacteria, E. coli, Pseudomonas, Klebsiella, and Serratia. Initial therapy, for example, flucloxacillin and gentamicin, is aimed to cover most Staphylococcus and gram-negative bacilli. If the organism resistant to these antibiotics or the infant's condition does not improve, specific antibiotics, for example, vancomycin for coagulase negative staph or enterococci or broad-spectrum antibiotics, meropenem may be indicated. Use of prolonged or broad-spectrum antibiotics predisposes to invasive fungal infections, Candida, in premature babies. Serial measurements of an acute phase reactants are useful to monitor response to therapy. Neonatal meningitis, although uncommon, has a mortality of 20 to 50%, with one-third of survivors having serious sequelae. Presentation is non-specific. A bulging fontanelle and hyperextension of neck and back. Opisthotonus are late signs of really seen in newborn infants. And meningitis is thought likely. Ampicillin or penicillin and a third-generation cefotaxime, which has CSF penetration, are given. Complication includes cerebral abscess, ventriculitis, hydrocephalus, hearing loss, and neurodevelopment impairment. Subspecific infections. Group B streptococcal infections, around 10 to 30% pregnant women have fecal and vaginal carriage of group B streptococcus. The organism causes early onset, late onset sepsis, and early onset sepsis in newborn baby has respiratory distress and pneumonia. In the UK, approximately 0.5 to 1 per thousand babies have early onset infection. Most have pneumonia only, but it may cause septicemia, meningitis. Mortality in babies with positive blood or CSF cultures is up to 20%. Up to half of infants born to mothers who carry group B streptococcus are colonized on the mucous membranes of skin. Some of these babies develop late onset disease up to 3 months of age. It usually presents with meningitis, occasionally with focal infection, for example, osteomyelitis or septic arthritis. In colonized mothers, risk factors for infections are preterm, prolonged rupture of membranes, maternal fever during labor more than 38 degrees Celsius, maternal chorioamnionitis, or previously infected infant. Prophylactic intrapartum antibiotics given intravenously to the mother can prevent group B streptococcus infection in the newborn baby. There are two approaches to the use of intrapartum antibiotics versus screening at 38 weeks to identify mothers who carry the organism practice as practiced in the USA and Australia, and a risk-based approach in which mothers with risk factors for infections are offered antibiotic, as in the UK. Group B streptococcus infection is a serious bacterial infection in terms as well as preterm infants from birth to 3 months. Listeria monocytogenes infection, fetal or newborn listeria infection is uncommon but serious. The organism transmitted to the mother in food such as unpasteurized milk, soft cheeses, and undercooked poultry. It causes bacteremia, often with mild influenza-like illness in the mother and passes to the feeder via the placenta. Maternal infection may cause spontaneous abortion, preterm delivery, or fetal neonatal sepsis. Characteristic features are meconium staining of the liquid amni, unusual in preterm infants, a widespread rare septicemia, pneumonia, and meningitis. Mortality is 30%. Gram-negative infections, early onset infections required in the same way as group B streptococcal infection. Late onset infections is usually from infectious CV lines, central venous lines, occasionally from translocation from the intestine to circulation. Conjunctivitis. Sticky eyes are common in natal periods starting on the third or fourth day of life. Cleaning with saline and water is all that is required, and the condition resolves spontaneously. A more troublesome discharge with redness of the eyes may be due to staphylococcal or streptococcus infection and can be treated with a topical antibiotic eye ointment, for example, chloramphenicol and neomycin. Purulent discharge with conjunctival injection, swelling of the eyelid within the first 48 hours of life may be due to gonococcal infection. This discharge should be gram stained urgently, as well as cultured and treatment started immediately, as permanent loss of vision can occur. In countries such as the UK and the USA, where penicillin resistance is a problem, a third generation cephalosporin is given intravenously. The eye needs to be cleansed frequently. Chlamydia trachomatis eye infection usually presents with a purulent discharge together with swelling of the eyelids at 1 to 2 weeks of age, but maybe also present shortly after birth. Organism can benefit with immunofluorescence staining. Treatment is with oral erythromycin for 2 weeks. The mother and the partner also need to be checked and treated. Umbilical infection. The umbilical dries and separates during the first few days of life. If the skin surrounding the umbilicus becomes inflamed, systemic antibiotics are indicated. Sometimes the umbilicus continues to be sticky as it is prevented from involuting by an umbilical granuloma. This can be removed by applying silver nitrate while protecting the surrounding skin to avoid chemical burns, or by applying a ligature around the base of the exposed stump. Picture shows purulent discharge together with the swollen eyelids in an 8-day-old infant. This is the characteristic presentation of conjunctivitis or primary trachomatis. Neisseria gonorrhea was absent. Herpes simplex virus, neonatal herpes simplex virus, is uncommon, occurring 1 in 3,000 or 1 in 20,000 live births. HSV infection is usually transmitted during passage through an infected birth canal, occasionally by sending infection. Risk to an infant born to a mother with a primary genital infection is high, about 40%, whereas the risk from recurrent maternal infection is less than 3%. In most infants who develop HSV infection, the condition is unexpected. The mother does not know that she is infected. Asymptomatic or non-specific illness. Infection is more common in preterm infants. Presentation is at any time up to 4 weeks of age with localized herpetic lesions on the skin or eye, or with encephalitis or disseminated disease. Mortality due to localized disease is low, but even with the acyclovir treatment, disseminated disease has a high mortality with considerable morbidity after encephalitis. If the mother is recognized as having primary disease or develops genital herpetic lesions at the time of delivery, elective C-section is indicated. Women with a history of recurrent genital infection can be delivered vaginally, as the risk of neonatal infection is low, and maternal treatment before delivery minimizes the presence of virus at delivery. Acyclovir can be given prophylactically to the baby during the at-risk period, but its efficacy unproven. Hepatitis B infant of mothers who are Hep B surface antigen positive should receive Hep B vaccination shortly after birth to prevent vertical transmission. The vaccination course needs to be completed during infancy and antibody response checked. Babies are at high risk of becoming chronic carriers when their mothers are E antigen positive but have no E antibodies. Infants of E antigen positive mothers should also be given passive immunization with hepatitis B immunoglobulin soon after birth, definitely within 24 hours of birth. Infants of hepatitis surface antigen positive mothers should be vaccinated against Hep B. Now, hypoglycemia is particularly likely in the first 24 hours of life in babies with intravenous and growth retardation who are preterm, born to mothers with diabetic mellitus, are large for days, hypothermic, polycythemic, or ill for any reason. Growth restricted and preterm infants have poor glycogen stores, whereas infants of diabetic mother have sufficient glycogen stores, but hyperplasia of the islets in the pancreas causes high insulin levels. Symptoms are jitteriness, irritability, apnea, lethargy, drowsiness, and seizures. There is no agreed definition of hypoglycemia in the newborn. Many babies tolerate low blood glucose levels in the first few days of life as they're able to utilize lactate as energy store. Some studies suggest that blood glucose levels above 2.6 millimole per liter are desirable for optimal neurodevelopmental outcome. Although during the first 24 hours after birth, many asymptomatic infants transiently have blood glucose levels low below this level, there is a good evidence that prolonged symptomatic hypoglycemia can cause permanent neurological disability. Hypoglycemia can usually be prevented by early and frequent milk feeding. In infants at increased risk of hypoglycemia, blood glucose is regularly monitored at the bedside. If an asymptomatic infant has too low glucose values below 2.6 millimole in spite of adequate feeding, or one very low value, less than 1.6 millimole per liter, or become symptomatic, glucose is given by intravenous infusion, aiming to maintain the glucose level over 2.6 millimole per liter. The concentration of the intravenous dextrose may need to be increased from 10% to 15%, even 20%. Abnormal blood glucose results should be confirmed in laboratory. High concentration IV infusions of glucose should be given via a central venous catheter to avoid extravasation into tissues, which may cause skin necrosis and reactive hypoglycemia if there is difficulty or delay in starting infusion or a satisfactory response is not achieved. Glucagon can be given. Neonatal seizures. Many babies start to have tremors when stimulated or make strange jerks during active sleep. By contrast, seizures are unstimulated. Typically, they are repetitive, rhythmic clonic movements of the limbs that persist despite restraint and are often accompanied by eye movements and changes in respiration. Many neonatal units now use continuous single-channel electroencephalogram, amplified integrated electroencephalogram (AEEG), also called a cerebral function monitor, to be able to confirm changes in electrical discharges in the brain. The cause of seizure lists in box. Whenever seizures are observed, hypoglycemia meningitis need to be excluded or treated urgently. Cerebral ultrasound was performed to identify hemorrhage or cerebral malformation. Identification of some cerebral ischemic lesions or cerebral malformations require MRI scans of the brain. Treatment is directed at the cause whenever possible. Ongoing or repeated seizures are treated with an anticonvulsant, although the efficacy in suppressing seizures is much poorer than in older children. The prognosis depends on the underlying cause. The causes of neonatal seizure: hypoxic ischemic encephalopathy, cerebral infarction, septicemia, meningitis. Metabolic is hypoglycemia, hyponatremia, hypocalcemia, hypermagnesemia, inborn error of metabolism, pyridoxine dependency, intracranial hemorrhage, cerebral malformations, duct withdrawal, for example, maternal opiates, congenital infections, cardiac arrest. Now, the next one is perinatal stroke. These result from cerebral vascular injury in the fetus or neonate. The commonest cause is ischemia of the middle cerebral artery. Other causes are hemorrhage or venous thrombosis in the dural venous sinuses. They present with seizures at 12 to 48 hours in a term infant. The seizures may be focal or generalized in a contrast to infant with HIE. There are no other abnormal clinical features. Diagnosis confirmed by MRI. Mechanism of perinatal arterial ischemic stroke is thought to be thrombotic, either thromboembolism from the central vessel or sometimes secondary to inherited thrombophilia. Nearly 50% develop motor disability, usually a hemiplegia of the contralateral side presenting in infancy or childhood, and some cognitive dysfunction. Large lesions may result in epilepsy. The MRI showing the imaging scan showing infarction in the tertiary branch of the left middle cerebral artery. As one as craniofacial disorders, cleft lip and palate. Cleft lip may be unilateral, bilateral, results from failure of fusion of frontonasal and maxillary processes. In bilateral cases, the premaxilla is anteverted. Cleft palate results from failure of fusion of palatine processes, and the nasal septum, cleft lip, and palate affect about 0.8 per thousand babies. Most are inherited polygenically, but they may be a part of syndrome or multiple abnormalities, for example, chromosomal disorders. Some are associated with maternal anticonvulsant therapy. They may be detected on antenatal ultrasound scanning. Surgical repair of the lip usually takes place at about 3 months of age. The palate is usually repaired at 6 to 12 months of age. A cleft palate may make feeding more difficult, but some affected infants can still be breastfed successfully in bottle-fed babies. If milk is observed to enter the nose and cause coughing and choking, special teats and feeding devices may be helpful. Orthodontic advice and a dental prosthesis may help with feeding. Secretory otitis media is relatively common and should be sought on follow-up. Infants are also prone to acute otitis media. Adenoidectomy is being avoided as a resultant gap between the abnormal palate and nasopharynx will exacerbate feeding problems and nasal quality of speech. Multidisciplinary team approach is required involving plastic ENT surgeon, pediatrician, orthodontic audiologist, and speech therapist. Parent support groups can provide valuable support and advice for families. Picture shows before and after operation of cleft lip. Photographs showing the impressive results of surgery help many patients cope with initial distress at having an affected infant. The next one is Pyruvate sequence is an association of myognathia, posterior displacement tongue, glossoptosis, and midline cleft to the soft palate. There may be difficulty feeding, and as the tongue falls back, there is obstruction to the upper airways, which may result in cyanotic episodes. The infant is at risk of growth faltering during the first few months. If there is upper airway obstruction, the infant may need to lie prone, allowing the tongue and small mandible to fall forward. Persistent obstruction can be treated using a nasopharyngeal airway. Eventually, the mandible grows and these problems resolve. The cleft palate can then be repaired. Now, the GIT disorders, esophageal atresia. Esophageal atresia is usually associated with tracheoesophageal fistula. It occurs in 1 in 3,500 cases. 1 in 3,500 life is associated with polyhydramnios during pregnancy or an absent stomach bubble or antenatal ultrasound scanning. If suspected, a wide caliber feeding tube is passed after birth and checked by X-ray to see if it reaches the stomach. If not suspected before birth, clinical presentation is with persistent salivation and drooling from the mouth. If the diagnosis is not made at this stage, the infant will cough and choke when fed and have cyanotic episodes. There may be aspiration into the lungs of saliva or milk from the upper airways and acid secretion from the stomach. Almost half of the babies have other congenital malformation, for example, as part of the vertebral, anorectal, cardiac, tracheoesophageal, renal, and renal limb anomalies, lateral association. Continuous suction is applied to tube passed in the facial pouch to reduce aspiration of saliva secretions, pending transfer to a neonatal surgical unit for correction. Following surgery, there are a number of known later complications, including gastroesophageal reflux, chronic cough, and sometimes facial dilation is required in infancy or childhood. Small bowel obstruction. This may be recognized antenatally on ultrasound scanning. Otherwise, small bowel obstruction presents with persistent vomiting, which is bile stains unless the obstruction is above the ample of water. Meconium may initially be passed, but subsequently special is usually delayed or absent with no transition to normal stool. Abdominal distension becomes increasingly prominent the most distal the bowel obstruction. High lesions will present soon after birth, but low obstruction may not present for some days. Small bowel obstruction may be caused by atresia or stenosis of the duodenum. One-third have Down syndrome. It is also associated with other congenital malformation, atresia, stenosis, jejunum, ileum. There may be multiple atretic segments of bowel. Malnutrition with volvulus, a dangerous condition as it may lead to infarction of the entire gut. Dan Midgut figure shows esophageal atresia and tracheophysal fistula. 86% have atresia with fistula between distal esophagus and trachea. 8% have atresia without fistula, and 4% have H-type fistula without atresia. Figure shows abdominal extended atresia showing a double bubble sign from distension of stomach and duodenal cap, the absence of air distally. Meconium ileus thick inseparated meconium of putty-like consistency becomes impacted in the lower ileum. Almost all affected neonates have cystic fibrosis. Meconium plug of insipid meconium causes lower intestinal obstruction. Diagnosis is made on clinical features abdominal X-ray showing intestinal obstruction, atresia, stenosis of bowel, and malnutrition are treated surgically. After correction of fluid and electrolyte depletion, meconium plug will usually pass spontaneously. Meconium ileus may be dislodged using gastrographin contrast medium, but otherwise will require surgery. Large bowel obstruction. This may be caused by Hirschsprung disease, absence of myenteric nerve plexus in the rectum, which may extend along the colon. It is more common in boys and in infants with Down syndrome. The baby often does not pass meconium within 48 hours of birth and subsequently abdomen distends. About 15% presents as an acute enterocolitis. Rectal atresia, absence of the anus at the normal site. Lesions are high or low, depending on whether the bowel ends above or below the levator ani muscle. In high lesions, to the fistula to the bladder urethra in boys or adjacent to the vagina or to the bladder in girls. Treatment is surgical. Bile stained vomiting is from intestinal obstruction until proven otherwise. Now this is the picture showing small exomphalos with loops of bowel confined to the umbilicus. Care needs to be taken not to put a cord clamp across these lesions. Exomphalos and gastroschisis, these lesions are often diagnosed antenatally. In the exomphalos, also known as omphalocele, the abdominal contents protrude through the umbilical ring covered with a transparent sac formed by the amniotic membrane and peritoneum. It is often associated with other major congenital abnormalities. In gastroschisis, the bowel protrudes through a defect in the anterior abdominal wall adjacent to the umbilicus, and there is no covering sac. It is not associated with other congenital abnormalities. Gastroschisis carries a much greater risk of dehydration and protein loss, so the abdominal affected infants should be covered with a clear occlusive wrap to minimize fluid and heat loss. Nasogastric tube is passed and aspirated frequently in intravenous fluids given. Replacement of fluid loss is often required early on to prevent hypovolemia. Many lesions can be repaired by primary closure of the abdomen. With large lesions, the intestine is enclosed in a celastic sac sutured to the edges of the abdominal wall, and the contents gradually return into the peritoneal cavity. Child protection in the newborn. Already during pregnancy, there is need to consider if there are any child protection issues that may arise when the baby is born. This may be because the mother is abusing alcohol or drugs, or due to maternal mental health problems, or when the family background, for example, avoidance of previous child protection problems, could compromise the health and well-being of the newborn. Premature infants may be especially difficult to manage at home after discharge and are at increased risk for child abuse. To avoid potential child protection concerns later in childhood, in normal infants, any abnormalities found during the routine examination of newborn must be fully described and documented. For example, Mongolian blue spots, as they are mistaken for bruising, and subconjunctival hemorrhages following delivery, which may be mistaken for non-accidental injury. Thank you very much.